are these people asking for this information? Well, reality, it's everyone. So the big ones, of course, we think about are CMS and the Joint Commission. But the reality is that we're having equal pressure from third-party payers, other regulators, not Joint Commission or Medicare, local governments, so state governments, even maybe local governments, depending on where you are, providers and other healthcare professionals. So we're getting quite a push for people to ensure that people are quality organizations and they have vetting process so that when you refer your patients there, you know what type of quality you're getting. Patients and patients are demanding this as well, and you see this with the onslaught of new websites that are looking at rating providers and rating clinical experiences. So there's lots of different people asking for it. One of the ways that providers and medicine has responded is been the credentialing process. So the credentialing process, this is not a history of how this came about, but thinking about where we were in the 1970s and 1980s, and you had books like The Blind Eye, where it was a mass murderer who was credentialed and was given state license in many different states, and states weren't communicating with each other. So these processes that we have a standardized process that thoroughly vets people and their backgrounds is really important to providing safety and security for and a feeling of security for our patients. Next slide, please. So who does this affect? Well, certainly members of the medical staff, and we all can kind of think of easy definitions of medicals and member staff would be the medical physicians and the doctors of osteopathy, podiatrists, dentists, who are physicians and are members of the medical staff by most all hospital bylaws. It also includes other licensed independent practitioners. So who are these licensed, other licensed independent practitioners? Well, the definition of that is variable by your organization. It's variable by state law. Government agencies, and we'll get to this in a second, provide a little bit of framework for this, but again, their framework is mixed depending on their view. And then, like I said, hospital bylaws play a lot into who you define as licensed independent practitioners. Also, who makes up members of your medical staff, formal medical staff, also are determined by your state law, as often states will comment as to who can be members of the medical staff, and then, of course, your hospital bylaw. Next slide, please. So, give you some examples of how it's defined. So, Joint Commission says that it does not determine whether a specific practitioner is a licensed independent practitioner, but it defers to state law for the determination. CMS requires credentialing of all practitioners who provide medical level of care and/or conduct surgical procedures in the hospital with its conditions within its conditions for participation. The test as to whether somebody's providing medical level of care has tended to be whether they collect a history or physical. And so when you look at the language put out by both Joint Commission and by Medicare, they'll talk about whether somebody performs medical history and physical examinations and then goes on to make medical decisions based on that, is usually the acid test as to whether somebody is providing a medical level of care. So CMS also spells out that it requires initial and ongoing review of licensure, current work practice, special education or training, quality of specified work, outcomes, regular national provider database review, whether providers are compliant with bylaws, whether they're compliant with state law, whether they're compliant with the local regulations surrounding their practice, and a log of their CME. And so for any providers on the line, as we get these calls for our recertification, our recredentialing, you'll know that most hospitals ask forms that have all these questions on it, and the reason is that they're trying to meet that CMS requirement. Next slide. HRSA defines licensed independent practitioners as a physician, a dentist, a nurse practitioner, a nurse midwife, or any other individual permitted by law and the organization to provide care and services without direction or supervision within the scope of license, consistent with individually granted clinical privileges. As a PA, we've defined this as this also applies to PAs, but it could also apply to some nurse specialists or, again, nurse midwives are of course listed. Next slide, please. So this is a handy little chart from the Joint Commission right out of their documents that talks a little bit about who needs competency evaluations. And so you have on the left blue bubble, you have physicians, other licensed individual practitioners, and people who provide CMS's definition of medical level of care, that is, performs a history and physical examination and then makes a medical decision. And so when you move to the right, if these people are individuals of the medical staff, then yes, they need to have a competency evaluation. If they're not, but they are meeting this level of medical care and the bylaws say that somebody who's providing medical care needs to be evaluated, which the agencies all say, then you would need to be credentialed and privileged by the medical staff. And so NPs or PAs typically fall into this here, where that they may not be members of the medical staff, but the contracted standards apply, and therefore they would need to be credentialed and privileged, and therefore have a competency evaluation. Next slide, please. So one of the questions that comes up a lot is, are advanced practice nurses, and for the rest of the talk, when I say advanced practice nurses, I will mean certified nurse midwives, nurse practitioners, certified nurse anesthetists, and some of the nurse specialists, clinical specialists who are providing medical level of care. Again, that tends to be pretty state dependent. In some states, certified nurse specialists provide independent care like that. So when I use the term APN or advanced practice nurse, that's who I'm referring to, unless I say otherwise. So NPs and PAs are allowed to be members of the medical staff by both Joint Commission and Medicare's conditions of participation if allowed by state law. So there are some states where the state law dictates who can be members of medical staff. If it does not specify otherwise, though, NPs and PAs can be. Similarly, you may grant privileges without granting membership to the medical staff. So you can credential and provide privileges to somebody without having them a member of their official medical staff. Next slide. One of the things that we are seeing in terms of best practice is that physician assistants and APNs who are credentialed and privileged are becoming official members of the medical staff and are sitting on the appropriate committees, and this really provides NPs and PAs a voice in developing and implementing the hospital medical staff policies. As we talk about later on a little bit about peer assessment, you'll see that the peer assessment, that is somebody of the same profession who's evaluating you, is key to a lot of these processes. Having NPs and PAs involved in the medical staff and sitting on the appropriate committees and having a say in this really does help streamline these processes. I've included a link to a website here on a policy statement from the American Academy of Physician Assistants that talks about the practice of PAs and NPs sitting on medical staffs. Next slide, please. So just overview of credentialing and privileging, that APNs and PAs must be credentialed and privileged through the medical staff process per the Medicare and Joint Commission. It's no longer acceptable to use the, in quotations, equivalent processes through human resources that many organizations have used in the past. If these providers are using if these providers are providing a provider level of care, or a medical level of care, that is the assessment, the physical, the history, and the decision making, they need to be credentialed and privileged. And you need to use the same process of physicians, although you can use built-in structures. So for example, at Wake Forest Baptist Medical Center, we for the last several years have had an NP and PA sit on the regular credentialing committee. They've decided now, for streamlining purposes, we're going to actually have a credentialing subcommittee for NPs and PAs. We call it Advanced Practice Provider, or APP. So we're going to have a separate subcommittee that will review all those documents, send it to the credentialing committee for review, and then up to the medical executive committee. This is just to help streamline it, but the processes that we're using, the forms that we're using, the evaluations we're using are the same that we're using for physicians. Next slide, please. So bottom line, who needs to be credentialed? Just remember that you need to know the requirements based on state laws, conditions of participation, local payers. You need to specify in your bylaws who are considered the licensed individual practitioners within your organization, again, using that litmus test that we talked about. And then you need to make sure that all licensed independent practitioners are participating in the credentialing and privileging process. Again, any of these alternate pathways are really not accepted anymore. So for example, who gets credentialed at Wake Forest Baptist Medical Center? We credential physicians, medical doctors, doctors of osteopathy, dentists, advanced practice nurses, so certified nurse midwives, nurse practitioners, CRNAs, PAs. We have a few clinical pharmacists, so these are PharmDs who have gone through clinical training and are working in North Carolina. There's a law that allows them to have a limited scope of independent practice. So they are credentialed and privileged. Clinical psychologists, and podiatrists. You may have different lists at your organization based on what's applicable by state laws or within your hospital bylaws. Next slide, please. So again, what is the credentialing process? It's really three bits that we're going to talk about today. One is the general competency assessment, and then we're going to get into the heart of what we want to talk about, which is the FPPE and OPPE. Credentialing process also includes credential verification, but we're not really going to talk about that process today. Next slide. So for general competency assessment, it usually the Joint Commission standard is that it follows these 6 general competencies that has been endorsed by most medical and professional organizations. It's been validated. And so these 6 general competencies are patient care, medical knowledge, practice-based learning and improvement, interpersonal communication, professionalism, and system-based practice. Anybody in medical education will know that this looks very familiar. It was developed by the ACGME many years ago, and again has adopted its way through most medical association in terms of the general competency assessments. There's a document here that I attached from the American Academy of Physician Assistants that provides a little further detail from an NP or PA perspective about the general competencies. Next slide, please. I don't want to take too much time up on this slide, but just to know that there's many different competencies assessments, there's many different recommendations and requirements. It's important that you know what is specific for your organization. So the HFAP is the Healthcare Facilities Accreditation Program, which is a nationally recognized accreditation organization with deeming authority from CMS. Also, if you're a critical access hospital, an academic medical center, a government medical center like the VA, or on a military base, if you're a federally qualified health center, these all may have different requirements as to what's required. It's really important to know what classification you are and then to get your specific requirements. Next slide, please. So what does a general competency tool for APNs and PAs look like? Well, as many different hospitals, you're going to find as many different tools. I have yet to go into a hospital and see something that I've seen exactly somewhere else. It's always usually some variation. But importantly, you want to make sure that any kind of general competency tool has basically 2 elements. One is the assessment of core competencies for all APNs or PAs, and then one is you're going to have some specialty or department-specific competencies. Next slide. So this is an example in the next 3 slides here that is from the American Academy of Physician Assistant. You can certainly get it on their website. These slides were graciously, they gave me some information. Trish Marriott, who presented last month, had shown this during her talk then, and so I'm bringing it back as a tool. And it spells out a way to look at competency measure through a checklist, essentially, format. The third page, so move forward, please, 2. The third page here has an example of a specialty specific. So again, it's still general, so it's general for everyone in that specialty, but it includes some specialty specific. So within orthopedics, they have X-ray interpretation, fracture dislocation reduction, cast and splint application, assisted surgery, and medical management. And again, this is a lot of them. You don't have to have this many. They recommend at least 2 from a general category and from a specialty specific category. When I worked at Mayo Clinic prior to here, and I was the manager for the hospital medicine group of NPs and PAs, we used a model that looked at several things that are very specific for hospital medicine. So for example, we had as our criteria identification of sepsis, and we actually would have people go through the simulation lab and identify a patient with sepsis and have appropriate treatment and initiation of antibiotics and fluids within a certain period of time from the start of the case. We also had EKG interpretation. We had proper documentation and coding, and then we had a competency for end-of-life discussion. And for our specialty at our hospital, those 4 were seen as the key things that we wanted our NPs and PAs in hospital medicine to be able to do. Again, that list may vary depending on your specialty and depending on your hospital, but you do want to have both that general and specialty-specific competency list. Next slide, please. So general competencies, just remember that it's required of all credentialed providers within your institution, and you want to follow a process that is validated in line with the 6 general competencies endorsed by most specialty and professional organizations, the list that we provided above. Next slide, please. So let's really move into what we started by talking about today, which is the focused and ongoing competency assessments. You can't really talk about these without talking about the previous topics because the credentialing process and the general competencies are so ingrained in the focused and ongoing competency assessments. Next slide. OPPE and FPPE, as they are termed, it stands for Ongoing Professional Practice Evaluation, which is continuous evaluation of providers' performance at a frequency of greater than 12 months. Interestingly, they don't tell you exactly how often you need to do it, just to say that it needs to happen more than every 12 months. Most organizations that I've worked at have interpreted that as twice a year. So they'll do kind of a mid-year and end-of-year review. I know some organizations look at this 3 times a year. As long as you're doing the OPPE at least twice a year, you're going to be in compliance with the requirement. Focused professional practice evaluation is a defined period of more intense assessment of a provider's competence. And really it's going to apply in a couple different situations. One is anybody on initial credentialing, and when questions arise through OPPE or peer review about a provider's competence. So it's for everyone up front, and then it's as needed based on the results of the OPPE. Next slide, please. So principles of FPPE and OPPE include a peer-reviewed process. This is covered by the state peer review confidentiality privilege, and so information here does fall within that exception. The Joint Commission's definition of a peer is practitioners in the same professional discipline as the applicant who have personal knowledge of the applicant. That's defined as a peer by Joint Commission. Remember that your assessment should include both performance data, so actual hard data as in length of stay or some other measure, and narrative assessments, and it's ideal if it's by more than one person. So certainly this is a scale here, meaning that if there's only one or two other people in your department, then you can't have many. But ideally, you would have an assessment from a data standpoint, and then a narrative assessment from your peers and someone like your department chair. So these narrative assessments can include discussion with other individuals involved in the care of the patient, including physicians, allied health practitioners, nursing and administrative personnel. And so it's really meant to be a holistic review of a person's competency. Next assessment, or I'm sorry, next slide. So what happens if you don't have a like professional in your organization? I know in speaking with Trish Marriott at the AAPA, this question comes up a lot, and the Joint Commission actually has an answer, and I put the link below. Whenever, in situations where there's no nurse practitioner or physician assistant who could provide a peer reference, it is acceptable for a physician or DO with essentially equal qualifications who is familiar with the practitioner's performance to provide a reference. So for example, an internist could provide a reference for a PA working in an internal medicine specialty, an anesthesiologist for a nurse anesthetist. If you have a orthopedist, you'd probably want to have them do it for an orthopedic PA or a surgical PA, but you want to have somebody with ideally as best matched up credentials as you can. Given that most states require some relationship with a physician for PAs definitely, and for still some for nurse practitioners, you should be able to find somebody with like background or experiences. Next slide, please. So remember, all physicians currently undergo FPPE or OPPE, or at least they should be doing that. And to remember that that NPs and PAs also, if they're credentialed and privileged, need to undergo FPPE and OPPE. Now, many organizations have metrics or processes for physicians to undergo an FPPE or OPPE. Many of them will apply. So for PAs and NPs, I would, in my estimation, probably 80% of what, or 90% of what a physician goes through for the FPPE or OPPE would apply to a PA, but there are sometimes things that don't. The biggest challenge we run into is on the data side, specifically. So in some organizations, the data generated by an NP or PA gets rolled into the physician's data. So for example, things like readmission rates or NSQIP data, or patient satisfaction data, or complication rates will get reported through the physician. So in some cases it may be difficult. In those cases, Joint Commission and Medicare recommend a chart-by-chart review for some charts to see if people are compliant, although that can be very time-consuming, certainly. Other credentialed providers may have very different metrics, and so when you think about your clinical pharmacists or psychologists, some things may certainly apply in terms of general assessments, but they may have very specific things that aren't going to necessarily apply. Although there was a great study out of Massachusetts several years ago that showed that they had a single kind of process for looking at competency for all mental health practitioners. So they had physicians, both MDs and DOs, NPs, PAs, and clinical psychologists, and they had a 12-minute webinar video that they watched and then answered some questions to, and they used it as a way to measure competency and assessment, and it was found to be effective for all of the different professions equally, which was very promising. So again, sometimes these metrics can apply equally. This is really a model of keeping it simple. So you really want to keep it relevant and meaningful. So you don't want to collect data that it's not going to speak to their care, or that's not going to be applicable to their practice. You want to make it scalable. So it's great to be able to say we're going to have an in-depth, detailed report of every patient experience that walks through, But if your practice is seeing 15,000 patients a year, can you really deliver on that? And so what process seems to be great maybe for a small scale or individual clinic, think about scalability as it rolls out, and that process becomes your standard and needs to be rolled out across the organization. In that case, scalability is very important. The last thing that I think that people sometimes forget about is that we need to have profession buy-in. So it is getting, if you're developing competencies for clinical pharmacists or psychologists or NPs or PAs, including them in the process makes this always go a lot easier. Having their say as to this is important, this is relevant and meaningful, will save you a lot of time and effort on the back end when you have to reconcile these and get people's involvement, because ultimately the individual provider is the one that has to comply with this paperwork. Getting them to get buy-in up front makes it a lot easier. And remember, process, process, process. So the key on all of these things is that you want to have a process for it, you want to follow that process, you want to have the process clearly spelled out, and that you have contingencies. If somebody falls out of the process, there's a process to handle what happens when the normal processes fail. Next slide, please. So thinking about what already exists and what needs to be added, make it relevant at the department level. You want to have the processes for OPPE and FPPE clearly defined. You want to know who reviews it is clearly defined, what they're measuring is clearly defined, and what the triggers are. And we'll talk a little bit about triggers here in a second as to what triggers mean and what we want to look for them. Next slide, please. So ongoing performance evaluation we're going to talk about first. Next slide. So the OPPE, you see the standard from there for Joint Commission. Every credentialed and privileged provider needs an OPPE process. The type of data collected is actually determined by the individual specialty or department, and this is actually stated in the Joint Commission documents. Consistency is the key of process is key. So whatever you roll out and look at for people, you need to roll out and look at for individual things. One of the concerns that have been coming up recently, I've read about in some of the literature, is concerns about discrimination suits. So making sure that you have consistent processes across areas and that you're not picking people out or honing in on individuals when you don't have data to back up a more focused assessment. Variation of methods that need to include peer review. So again, it's not just having a department chair sign off as they've looked through a chart review. You want to have a couple different methods in addition to that. And then you want comparability to other like professionals. So again, you want to have, when they're looking at comparative data, you want to look at data that's comparative. So not all PAs necessarily have the same practice setting. So a PA in orthopedics may have a very different practice from a PA or an NP in hospital medicine. And so looking at making sure you're comparing apples to apples and oranges to oranges is key to the ongoing professional practice evaluations. Next slide, please. So what are some of the examples of data that you can collect? So HCAP score, core measure data, patterns of prescribing or blood usage. So this is not necessarily looking at it once, but it's getting reports and looking at trends. So you may say, we want to look at opiate prescribing over a 3-month or 4-month period for providers, and then pull the reports, and then say a provider is above the average or at the average. You want patterns of test prescribing. So does somebody order too many CBCs or not enough chemistries? You could look at length of stay, mortality readmission rates, peer assessment or supervisor assessment. So, for example, department chair or other NPs or PAs in your group. And then you can also look at patterns of interpretation of results. So, looking at does a particular physician does a particular PA in the emergency room setting get their X-rays overread at a higher degree of others in places where the ED would read their own films. So thinking about things like that. Next slide, please. So what key principle in OPPE is this theory of triggers. So you want to look for data. You want everyone to be evaluated who's credentialed and privileged on that data. What you then want to look for is to have a trigger level, which is essentially a predetermined, unacceptable level of performance within established criteria. So saying we don't want blood usage more than 7% of patients. So then saying if somebody has more than 7%, that would be a trigger for them to fall out of the normal OPPE process and require further review. So some examples would be a sentinel event. Certainly, we would expect that there would be no sentinel events, and so if somebody had a sentinel event, that would be a trigger that they would need to go in through a different process. Another example would be some percentage of negative events occurring. So for example, you could look at, like we talked about, blood usage, or another example could be readmission rates. So we anticipate a 2% readmission rate. Providers who have greater than that would automatically fall out of the normal OPPE process and then require an FPPE. This is interesting that came out of the Joint Commission 2013 in their document. It specifically says in their document, if triggers are never activated, then likely your triggers are not sensitive enough. And I know this is something that they've been looking at, and so you do want to make these triggers meaningful so that it's not ever never events, that you want to have things that happen, and that ideally there should be further reviews on some providers, and you just need to make sure you find it so it's not too sensitive, but but you also want to make sure there is some sensitivity and sensitive enough. Next slide, please. So what are the collection methods? You can use direct observation, chart review. You can do discussion with peers, staff, providers, observation or performance of, you can watch a test or a procedure. There's actually some resources that tell you how to handle that with patients. There's a couple of resources I saw that tell you how to have those conversations with patients as to why you're there in the room with the other provider. What we've done at Wake Forest Baptist Medical Center is in North Carolina, every 6 months for established PA and NPs, with their physicians, they need to have a supervising physician or a collaborating physician report, and it's a report that you fill out and then you file with your practice. We've actually combined we're in the process of combining our OPPE processes into that, so that when you're doing your normal supervising physician documentation, you can include your OPPE as a process of that. And so that's something that we're getting ready to roll out. When I was at Mayo Clinic, we actually we piloted using simulation for this. And in people who have simulation labs, it works really well. It gets it all done in one day. We were able to mark it off and observe people and be able to do it all in one day as opposed to stretching it out. It was a really effective process. Next slide, please. So just thinking about that, this must be separate from any annual review. So in many organizations, NPs and PAs are considered staff, and so may have a staff performance review. But just remember that the Joint Commission's expectation is that this is separate from HR processes. So this OPPE is a separate process from that, not included in that. You really want a mix of general and specialty-based OPPE, so thinking about 2 general things like readmission rates or blood usage, and then at least 2 specialty-specific ones. What you use for physician OPPE may or may not work based on bylaws, reporting mechanisms, and workflows. So like we talked about, sometimes NPs and PAs data is reported up through the physician, and in that case you wouldn't have necessarily the data. So you would need to build workaround processes for evaluating APNs and PAs in those situations. Next slide, please. Okay, so what about a situation when you have no data? Well, that is actually potentially okay. Click again, please. No reported data on a complication is actually data. So if you've had no complications, that is data, And that's a very positive thing. You don't want to have complications. So having no complications is a really great thing. And if you say there were no complications in this period of time, it was reviewed and you signed off for it, that's an easy one to do, and that's a very positive one. But something like no data about a length of stay is incomplete and inaccurate, because you actually do have data about length of stay, you've just not reported it into that format. And so that could potentially be a problem if you're saying that there is no data. There is data. It may be that there is no data, and that's a good thing, or it may be that there's no data because we haven't looked. And so no data because we haven't looked is potentially bad. No data because it was no bad events reported is very good. So just thinking about how to handle those no data situations. Next slide, please. So bottom line for OPPE, that it's required of all credentialed and privileged providers. You need a mix of general and specialty-based OPPE. Providers may not understand this process, and I think that even now as I go out and talk to different NP and PA leaders, as I talk to leaders in different professions in my work, as I go out and consult with different hospitals and meet with different leaders, there's really not a great understanding about OPPE or FPPE, and from the provider standpoint at least. And so for our credentialing and privileging specialists and executives on the call, you really need to make sure that the providers become aware of this process, you educate them about this process, and then you engage them. And then just keep in mind that OPPE needs to be done for everyone who's licensed, who's credentialed and privileged. It needs to happen at least twice a year, and it happens to everyone. Who falls out of OPPE determines who needs the FPPE. And that'll walk us into FPPE, which is the very next slide, please. Next slide. So FPPE is a much different process. Similar but different, and essentially there's the standard. It says the organization's medical staff evaluated and acts upon reported concerns regarding a privileged practitioner's clinical practice and or competence. So you need to perform FPPE for a couple situations. Number one, everyone who is hired when privileges and credentialing is first sought need to undergo a FPPE process. So this is regardless of performance in the past. If you're newly privileged and credentialed, you need to have, every provider needs to have an FPPE process. So when privileges are requested, that's when it needs to be done. You also do it when there's a concern identified within the OPPE. So we talked about when somebody triggers an OPPE event or review, that would then fall into an FPPE process. There are some growing body of literature to say that in people with prolonged leave of absences, this is becoming more and more common, and that FPPE is probably appropriate in those situations. Additionally, your hospital may have some specific bylaw about when that a focused professional practice evaluation needs to be performed. I know one of the real hot topics in credentialing and privileging is late career providers, and when you need to start performing, if you need to start performing FPPE on them. And we'll discuss that a little bit at the end of this section, but just to know that some hospital bylaws actually have are written to include this. Next slide, please. So the key elements that you need to have are clear guidelines and benchmarks. You need to have criteria for conducting the evaluation. So when do you do it? Who do you do it? Method for establishing the monitoring plan specific for the requested privilege. So essentially the who's going to do it. A method for determining the duration of performance monitoring. Again, who's going to determine that? How long does it need to be? Is it the same length for everyone? And then number 4 is the circumstances under which monitoring by an external source is required. So this would be somebody has triggered an OPPE review, and so they move into an FPPE process. And so do you have processes to fall out to say if somebody's FPPE fails and they need further review, how does that happen? Is it somebody external to the institution? Is it somebody external to the department? But within the institution, how do those processes fall? So an example of what we're starting to roll out at Wake Forest Baptist with NPs and PAs in a couple different specialties. Right now we have it rolled out in critical care and in hospital medicine, which is we have a daily log for new providers. They look at what conditions they saw, what procedures they performed. It's signed off by whoever they're working with that day. Weekly, the supervising physician reviews those for 8 weeks, makes a report, and we then, at the end of this period of time, have a daily log that the person keeps, that gets signed off on. Then we have these weekly reports, and we then have processes built in to say if somebody doesn't meet expectations on a given day or a given week, there's a process for that. Next slide, please. Some FPPE truths, and this is the Joint Commission edition. So this, I pulled these straight out of the Joint Commission. One is processes used for FPPE do not need to be the same for everyone, just consistently applied. Meaning that you can have a different process for people that are internal trainees. So somebody, say, for example, who's a resident at your institution, because you may have data on them, you don't need to necessarily have the same process. You need to have a process, and they need to undergo FPPE, but it doesn't need to be the same as somebody who's, say, a resident from a different hospital who you have no data for. The key is that you spell that out very clearly and that you hold to that and you don't have exceptions. Another truth is that training, so whether it be a weekend course, a CME, even a PA program or a medical school program or an NP program, does not equal competency. So you need to actually, just because somebody's graduated or graduated with honors or gone to a course, that doesn't necessarily mean that they're competent. Another truth is that board certification does not equal competency. Just because somebody's board certified does not necessarily make them competent by Joint Commission standards, and they have to have their competency assessed through the FPPE and then ongoing performance evaluation. 4, sampling of group privileges does not mean somebody is competent in every privilege in that group. And so what happens occasionally is that institutions may say all surgery is lumped into one group, and that we'll just spot check them in, say, a knee replacement and a shoulder replacement, and if they're good, then they can do any orthopedic procedure. What Joint Commission says is that if you group privileges, you need to check every privilege to say whether they're competent or not. Just because somebody can, say, perform a knee replacement of a certain type of knee replacement doesn't necessarily make them qualified to immediately do a hip replacement or an elbow replacement in any situation where you're trying to group privileges. The last point, which is one that I hear gets mixed up a lot, is specialty-specific data or indicators for the same privilege are managed the same way for all practitioners with that privilege. So what does that mean? Well, what it's saying is that if you are, say, credentialing somebody and privileging somebody for a central line placement, the indicators that you use, the privileging process, the FPPE process that you use for that central line needs to apply whether an NP is putting it in or a PA is putting it in or a physician is putting it in. If you have a different standard, then the person shouldn't be privileged in that skill and they need to have some other mechanism. But if you're saying that you're privileging somebody for a central line, a specific type of central line, then everyone who does that central line, regardless of the profession, needs to be held to the same standard. Next slide, please. So what's the key? Again, we talked a little bit about this. The key is defining the who, where, how of improvement. Need to identify the areas of concern and development, how much time you're going to allot to this assessment, how the assessment occurs, who's going to actually collect the data, who's going to pay for it, the what happens if, so this is our contingency plans, right? This is what happens if the person fails the FPPE process, what happens to them then? Who gets involved? And then you also need to know if they are in an FPPE process and they successfully remediate it or pass it, then how, when and how do you need to perform an FPPE in the future? And again, this should be specified in your bylaws. Next slide, please. So some special considerations. As we talked about, there are quite a few growing resources for FPPE assessments for late career clinicians. I have a couple. I'm happy to email them to anybody who's interested and emails me. But just to know that this is a very hot topic. It's clearly a very sensitive topic. Can be very difficult in some organizations. We've just started tackling this at our organization and involving compliance and legal, because certainly there can be legal considerations involved in this as well. So getting a good resource for this and being thoughtful in your discussions about what the bylaws should say about this. Special consideration, what about a weekend course designed to provide proficiency with a new skill? Why can't we just use those as FPPE? So this would be somebody goes to a Botox course, say, and learns how to inject Botox. Can they just come back and start doing Botox injections the next week? Really, no, because it says that you cannot use external sources. You need to use your own internal assessment. And so really, whatever assessments or evaluations they provided at that course do not necessarily make them competent within your facility. You can only determine that, not somebody else. And so before they could really do that procedure, you need to have them perform it in the FPPE process. And then finally is, how do you measure low volume procedures or providers? Another challenging situation, lots of different mechanisms that people have used. Simulation is something that I've had a little experience with that it seems to have worked pretty well. The literature has quite a few different ideas, and I'm happy to hear anybody other's suggestions when we get to the questions, ideas of what they've done for low volume procedures or providers. Next slide, please. So FPPE considerations for NPs and PAs. Again, really for NPs or advanced practice nurses and PAs, it's really essentially the same processes for physicians. Just to understand that physicians probably accounts for this as well. Most APNs and PAs have limited understanding of this process. So again, helping them understand when you're planning these activities and planning the bylaws and the guidelines that you have both involvement from the APNs and PAs, but then also have some education and understanding of what this process is. Next slide. So bottom line, just remember that it needs to be done initial hire, and when there's concerns about OPPE, consistency in processes are key. Training and or certification do not confer competence, so you need to do your own assessment. And the performance plan is a key component of an FPPE process, and really something that we don't have time to discuss today, but thinking about what the performance improvement that you're going to develop as a result of the FPPE is key. And that's certainly a good discussion for another chat. Next slide, please. So what are our take-home points here? Our take-home points are competency assessment occurs at both time of hire and ongoing. All licensed and privileged providers need an OPPE or FPPE process. Training does not infer competence. Providers may not understand that, so that needs to be explained. I hear this sometimes with PAs who say, well, I've taken my certifying exam every 6 years. That means I'm competent. Really, it doesn't, and that needs to be explained to a lot of different providers. I know until I started doing this, I didn't have a fair understanding of it just as a bedside clinician, and so it really does need to have better education around it. And then specialty-specific data or indicators for the same privilege are managed the same way for all practitioners with that privilege, again, regardless of their profession. Next slide, please. I provided some resources. symplr actually has some really great, a couple great, real short reads about focused and ongoing professional practice evaluations related to the electronic physician record. Also, there's a report on allied health professions OPPE. Two other resources are the Joint Commission Booster Pack. Oh, and I did provide the late career practitioner reference there. This was a pretty good reference that I saw, had a very detailed explanation on the concerns and the processes for it, and so it's there for your consideration. Next slide, please. A couple more references, and next slide, please. Thank you for your time and consideration. I'll turn this back over to our organizers.
Thank you so much, sir. And now we're going to pause for a brief commercial break to talk about symplr as it relates to the topic. symplr, formerly MedKinetics, has an easy-to-use, effective solutions to manage the complete life cycle of your providers. We offer provider credentialing, provider privileging, quality and performance improvement, and peer review solutions for your facility. If this sounds like something that would benefit your facility, please contact us at sales@symplr.com. That's sales@symplr.com.
So I'd really like to take some time in the we got about 5 or 6 minutes to hear from somebody. So hear from you. So are there concerns, challenges, questions in the development of OPPE and FPPE, especially if there's anything related to APNs or PAs or other licensed independent practitioners? Share your successes. If you've got great stories, this is a great place to do it. When you ask a question, it's best to identify who you are, the institution or the kind of organization you're affiliated with, like an academic medical center or a community hospital, what kind of people you're talking about, so who's credentialed, who's privileged, and then how many credentialed providers, just to give people an idea of whether it applies to their specific situation. Next slide.
All right, now it's time for our Q&A. Please submit your questions via the chat box on the right with all the information from the last slide. We would also like to remind everyone that you will be able to download an archive of this webcast along with its slides in a couple of days at symplr.com. You will also receive an email with this link that will come from communications@symplr.com. To ensure that you get this email, please add us to your address book. All right, our first question is, can you please clarify if FPPE is required for residents?
My understanding is that FPPE is not required for residents, as they are trainees, and so residents are not considered credentialed privileged providers. The one situation that I know we've had some discussion with lately is in regards to moonlighting and whether there's some very specific guidelines about that. I don't have all the resources for the medical education bits, but if you have residents who are moonlighting, that would be a group that probably does need to be credentialed and privileged, or fellows, for example, and that each institution has a little take as to how that means, and I think that there's been some recent clarifying language about that, but that would require a little further discussion than we have time for today. Thank you.
Thank you. Next question is from Suzette. She wanted to know, if we have a chiropractor and they're the only one here within that credential, do you know the requirements for the peer review or chart audit?
So my understanding from reading the Joint Commission is that when you don't have a like professional, you need to find somebody who's as much like that as possible. So I would imagine that depending on what the chiropractor was doing at your organization, you would want to think about a orthopedist or maybe a neurosurgeon or someone along those lines who could provide that peer review for that. So they look at it, you would ideally want to have somebody involved that is a peer. If there's not a peer, then going to the most closest who would represent that training and specialty.
All right, thank you, sir. Next question is from Ms. Connie. She asks, for FPPE and OPPE, are we allowed to obtain competency data for the physician's main hospital if they are low volume at our facility?
You know, this was I was at a conference a couple months ago, and this exact question was asked, and they had a lawyer who was running the conference, and they had mentioned that you really can't, that you need to have your FPP and OPPE data for your institution. And that, but in that, I haven't read it specifically that says it like that, but that was kind of the interpretation that they had given, that you really need to provide your own FPP and OPPE. So you would need to design an activity for that person within your facility. So maybe it's a simulation or maybe it's some kind of peer assessment, but my understanding is that it needs to be done internal to your organization.
All right, thank you so much, sir. The next question comes from Ms. Karen. She asked, do you have any suggestions on how to garner provider buy-in?
Yeah, that's a really great question. I think the very first thing is to have that engagement early on. A lot of times I've seen in a couple different organizations I've been in that processes are rolled out without any provider buy-in until it's time to have them fill out the forms. And so one process that we did really early on it when I was at Mayo Clinic several years ago is that when they were looking at redoing the process for NPs and PAs, they actually got a group of NPs and PAs to sit around and discuss this with some credentialing people and some physician leadership and discuss what an ideal process would look like and a little education as to why we have to do this and how we have to do this. And it helped give understanding to that group. That group then gave some really great suggestions and buy-in that they took forward. Most importantly, that group then became a group that could be your salespeople and going out and talking about the process with others and being your advocates for this process. So I think the very, very first thing to do is to look at the makeup of the committees and the structures that oversee these and to try to include as a diverse pool as possible. And then within that, build in focus groups or subcommittees that can maybe help provide some guidance for specific profession or specialty-based considerations.
All right, thank you so much, sir. That seems to be about all the time we have today. Would you like to make any closing statements?
I just want to thank everyone for their time today and their attention. Really great questions. My email is included in the slide deck, and I'm happy to provide provide any clarification or to have ongoing discussions. Please feel free to email me. Thank you again for your time and consideration.
Thank you so much, sir, and thank you all for joining us today. A recording of this webcast will be archived at symplr.com soon, and we will email you a link. Please also mark your calendars for our next symplr Education Series webcast with the CEO from CIHQ, Richard Curtis, to talk about health systems and the integrated medical staff. Hope to see you all there. Bye.